Hi guys, let's do this week's lab. This will be the lecture portion, and the star of the show today, auscultation of the abdomen. Here we go. Lots of good juicy questions could come from this presentation. The techniques are incredibly easy. Remember, that's not the hard part of passing the lab, it's passing these questions or getting through these questions. So here we go. The slide presentation is uploaded on Brightspace. So we did inspection last week, and after inspection comes auscultation. And in this procedure we'll check for bowel sounds, general auscultation, and then auscultation for bruise and friction rubs. So there's really 3 tasks. We'll do general auscultation of the abdomen, auscultate for specific bruise, which is what? Turbulent blood flow, and then friction rubs, which we'll get into. We'll be using the diaphragm for most of the examinations today. We'll be using the bell to check for bruise. Why is it done? People always ask me, how come this is done after inspection? Auscultation is often done last, right, in the thoracic exam. Why do you do it so early on? It's because if you do palpation first and you start poking around in the intestines, you'll mess up the natural peristaltic noises that are made by the intestines. And that, for general auscultation, that's about all we can know is how the frequency of those noises, called clicks and gurgles. We're going to be counting clicks and gurgles. If there's too many, it could be a certain disease. If there's too few, it could be a certain disease. So you don't want to go poking around in the belly until you do auscultation, because studies have shown it messes up the frequency of those bowel sounds. Either makes them too little or too frequent. Okay, 2 tasks again. We'll do general auscultation, and then we'll auscultate for bruise and friction rubs. Let's talk about general auscultation. The only function of general auscultation is to auscultate for bowel sounds, clicks and gurgles. Another thing you guys don't do correctly, you don't auscultate all 4 quadrants. All the board books, Bates, Seidel, Jarvis, McGee. Jarvis isn't even a board book. The good McGee, they all say you just need to put the diaphragm in 1 quadrant, and that's it. We'll use the right lower quadrant just to keep things simple. But really, I can't mark you off for auscultating for bowel sounds if you choose any quadrant. But you don't go to more than 1 quadrant, and I know that's what you do, and there's no reason for that, as we'll see here in a minute. Well, we'll see right now. Why do you only need to put the diaphragm on 1 quadrant? It's because bowel sounds are unpredictable. You can't tell where they are. If you put your stethoscope on McBurney's point in the right lower quadrant and you hear a sound and you think it's coming right underneath you, you think there's a problem with the ileocecal valve maybe, that bowel sound could be coming from the stomach, it could be coming from the sigmoid colon, all the way on the other side of the abdomen. There's good research on this, so you can't tell, so there's no sense wasting your time or the patient's time by going all over the place and looking for these things. Okay. What do we get from auscultating the abdomen? You can only tell, again, if there's too many clicks and gurgles or bowel sounds, so there'd be hyperactive bowel sounds, or there's not enough bowel sounds, hypoactive, or there's the normal amount of bowel sounds. Bowel sounds are called clicks and gurgles. Memorize that. Clicks and gurgles, C and G, clicks and gurgles. What causes them? It's not 100% understood what causes them, but it's thought to be the wet kind of pre-fecal material being pushed through the intestine via peristalsis, or being pushed or ground up in the stomach. So it's peristalsis or stomach processing that causes these. Memorize this. Normally, there should be between 5 and 35 clicks and gurgles per minute. So that would be 6 to 34, or between 5 and 35. Got it? Memorize that number. You should know that. You guys usually don't know this, but if you hear your stomach growling really loud, especially when you're hungry, that has a name. That's called Borborygmi. Borborygmi. Very loud hyperperistalsis. And we don't count that as a click and gurgle. In fact, if you hear that, you have to start over again. All right, what are decreased? What's the definition of decreased bowel sounds? So if you go below 5, so 1, 2, 3, or 4 in 1 minute, if that's all you hear, a patient has decreased bowel sounds. What could that indicate? Well, it could be just normal variant, but it also, especially if the patient is sick and not feeling well, it's a sign of peritonitis. And that's an inflammation of the peritoneal lining. Very dangerous because septicemia or sepsis can occur very easily if someone gets peritonitis. The other thing that could cause it is a late bowel obstruction. If you get, just like we talked about with the esophagus, with cancer, can cause a blockage of the lumen or the hole in the middle of the esophagus. You could get the same thing in the small intestines or the large intestines. So in late small bowel obstruction, you tend to have fewer clicks than gurgles than normal. Okay. What could cause increased bowel sounds? Well, if you have 35 or more clicks or gurgles in 1 minute, you have increased bowel sounds. What could cause that? Gastroenteritis, basically a virus or a bacteria that's invaded the intestinal wall, caused an inflammation. Diarrhea, which oftentimes is from gastroenteritis. Hunger could do it. Early intestinal obstruction could do it. Remember, late intestinal obstruction, the intestine just gives up trying to push fecal material through the block. Late intestinal obstruction, it gives up, so there's not many clicks and gurgles. But early in intestinal obstruction, peristalsis ramps up very strongly, and it creates more bowel sounds than normal. I think I have more slides on that. Absent bowel sounds are not good. And the patient has to be sick for this. You have to listen for 5 full minutes. And if you don't hear a single click or gurgle in someone who's sick, they go right to the ER. That's a problem, especially if they have other symptoms, stomach pain, fever, and such. That indicates, absent bowel sounds indicates a complete intestinal blockage, and it's usually a late blockage. What could cause that? Typically a condition called paralytic ileus, aka adynamic ileus, aka stasis. That's not a great aka for it. That means that the peristalsis has completely shut down in the stomach and small intestines and nothing's moving anywhere. We'll talk about this more in lecture, but surgical procedures are classic for doing this. Once you cut the peritoneum, it shocks everything and it takes a while for the intestines to wake back up again. Sometimes they don't wake back up again, which is trouble. McGee, I really like McGee. It's not a board book, but it puts a lot of well-read papers and papers that are published in well-respected journals. I really like McGee. Not the other McGee, the Maggie, M-E-G-G, the MCGG is a very well done evidence-based book. He says with regard to bowel sounds, it's very difficult to make heads nor tails of them. It's impossible to tell where they're coming from. That's why you only listen to one quadrant so you don't waste everybody's time. And the only purpose of the general bowel examination is to tell whether the bowel sounds are increased, decreased, or normal. Or maybe absent completely. All right. He also goes on to say that bowel sounds are made by peristalsis of the intestines and stomach contractions. And in order, based on research, The most common generator of clicks and gurgles is actually the stomach. Even though it sounds like it's coming in the right lower quadrant, it's really the stomach making that noise. It's in large intestines, and then the small bowel, small intestines are last. The overall frequency may change after a meal, so it's recommended that you do this examination not right after someone eats a big meal, or any meal for that matter. Small bowel obstruction we should talk about. Again, that is assessing frequency of bowel sounds is only fairly accurate when it comes to diagnosing small bowel obstruction, so it's not the greatest in the world. Animal studies have shown that if you artificially block the small intestine of an animal and see what happens, with the first 30 minutes there are hyperactive bowel sounds. Is peristalsis upstream from the blockage really ramps up to try to push through that blockage. After about 30 minutes, between 30 and 90 minutes, the peristalsis gives up and you have decreased bowel sounds, and they could disappear altogether. With regard to human small bowel obstruction studies, we've learned 40% of people present with hyperactive bowel sounds without any disease at all, so there's a huge false positive rates, so specificity is terrible. 25% have diminished or absent bowel sounds all the time. So, yeah, there's a problem with specificity for this. All right, the procedure, we already said, pick a quadrant, and we're going to choose the right lower quadrant. Use the bell, like this picture here. Don't touch the diaphragm with your fingers. You can use the kind of peace sign and push on the diaphragm, the sides of it, and push down and listen. Listen for 1 minute. Get your watch out and count the clicks and gurgles. All right. Step 2 is auscultating for bruise. So now bruise is bell, B and B. Remember that. So flip your end piece around and get to the bell of the stethoscope. Again, a bruise is turbulent blood flow. It's a whoosh, 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 usually heard in synchrony with systole. And it indicates turbulent blood flow, probably from an upstream aneurysm. Okay, let's try out my new drawing tools here and see if they work again for us. So let's do, here's a blood vessel. Right, and this blood vessel has a big aneurysm, a saccular aneurysm. Kind of looks like a diverticulum, but that's an aneurysm, and it looks like that. Okay, and blood's flowing, that way. All right, so the blood flow, try my color change here. The blood goes like this, and then some of the blood goes in here, and it just goes crazy in here and makes this crazy rushing sound as it swirls around there. And if you put your stethoscope, if you happen to put your stethoscope here on the skin and listen, you can hear that. You can hear that whoosh, whoosh, especially when systole, when the pressures get really high. So it could be an upstream. If you put the stethoscope here, you probably would hear it as well. If you put the stethoscope right over the top, you would definitely hear it if you went right over the top of it. If you put the stethoscope way down here somewhere, you're not going to hear it. So you have to be fairly close to it. So that's what we're looking for. Hopefully I didn't shut off the recording when I just did that. Okay, so we're looking for turbulent blood flow caused by an aneurysm. It could be caused by a beaver dam too. Let's try it again since we're on a roll here. So let's draw our, let's go back. Let's draw another scenario. And let's go blue. All right, so here's another blood vessel. And this time we have atherosclerotic plaque. So maybe there was an old catheter injury here, and it sparked the process of atherosclerosis in this area. And we know that these plaques can form. And here's another plaque that's been forming over the years. Okay, so if we get a situation like this, and this would be Mr. Spock. This guy has green blood, number 4. So the blood can go through here. I mean, here's the blood flow. And now, just like putting your finger over hose, right? It all has to squeeze through here. So that's like putting your finger over the hose. It's very high pressure that comes out of here. Very fast flow. The overall volume, it's still a beaver dam. Down here, you still have decreased blood flow. You have increased pressure up here because of the beaver dam. But if we put our stethoscope right over here, let's see. I think, am I out of colors? If we put our stethoscope right here, we will hear that. We'll hear that same turbulent flow because this will really spray during systole. So whoosh, whoosh, whoosh. We'll still hear the bruit. See how that works? All right, great. High-risk areas. So where do bruits occur? Where do aneurysms occur? The abdominal aorta, notorious, right below the renal vein. Just below the xiphoid process, the renal arteries, the iliac arteries, the common and the externals, the femoral arteries. These are the places where you have the best chance to hear a bruit. And we already did bruits last week. I mean, the carotid artery as well. Where are we auscultating? You can read exactly where we're auscultating. Let's just use the diagram. So here's the xiphoid process. So to auscultate, if I say auscultate for a renal or for a abdominal aortic aneurysm, so you will find the xiphoid and just go below the xiphoid, maybe just a hair to the left. Put the stethoscope right here and listen. 1001, 1002, 1003. With the bell, you're listening for whoosh, whoosh, whoosh. If I say find the renal arteries, you go out about 3 centimeters. Oh, let's see, what did we say here? Or 3 inches. I always forget if it's inches or centimeters. You go out 3 inches from the tip of the xiphoid. So 3 inches out. Okay, you're not quite in the midline. Friction rubs, we're going to be listening right in here below the costal margin. Just inside that is where you auscultate for the renal arteries. Okay, so if I say, let's check this patient out and make sure he doesn't have a renal artery aneurysm. So you do that, you auscultate right there, 3 inches out, right up against the costal margin here. You're not quite in the midclavicular line. All right, if I say auscultate the common iliac artery, they just call it the iliac artery, but it's common. You go just a little bit below the diaphragm, maybe a bell below the diaphragm, and out again in that same line, 3 inches out from the midline, right and left. Common iliac arteries. If I say go for the femoral artery, the ASIS, pubic tubercle, just guesstimate, and it should be just a little above that kind of crease in your leg there. Okay, probably won't go down that low in the exam, but should know where that is. Okay, if I say auscultate for venous hum, we might as well hit that where we're here. You just go in a circle around the belly button. People with cirrhosis of the liver can get this. And I don't think you know much about it, so we should talk about this venous hum, but that's where you are going to go. You can keep using the diaphragm or the bell. You could also use the diaphragm for this one. It doesn't really matter because the pitch is right in between those two sounds. So a venous hum, it's not a systole. It's not a whoosh, whoosh, whoosh. It's just a continuous sound that you hear. Kind of like a roaring or a humming sound. Kind of tough to imitate that one. But it won't be a systolic sound. It'll be a pan sound. A pan all the way through. So continuous. It's a continuous murmur. And what causes it is people with a beaver dam here. The hepatic portal vein is blocked. Usually people with cirrhosis of the liver, where they can't push blood through the liver because it's all scarred up. And so blood starts to back up, and it backs up and opens all these veins. This round ligament used to be a vein back in the day. This thing can open up again, and you can grow new collateral circulation around the belly button from these superior and inferior gastric epigastric veins also come into this area. These veins can get huge. They can cause varicose veins, caput medusa we looked at before. That's where these things come from. But if it's before that point, you can hear the turbulent blood flow of this venous hum. So that's where that comes from. Classically indicates cirrhosis of the liver. What is cirrhosis of the liver? That is a general term which means liver destruction. Basically, the cells of the liver are scarring up and no longer working. There's many different causes of it. The type of causes that cause a venous hum are hepatitis AC, like the AC, or California, CA. Shouldn't miss that, right? California. You can drink yourself into this condition. Alcoholic-induced liver damage scars up the liver, can't push blood through it, backs up. Or this weird non-alcoholic fatty liver disease, where the liver starts to fail and become cirrhotic because of fat infiltration. And we don't understand the mechanism of this. The liver gets really fatty. It's often seen in people who drink, people with diabetes, who have uncontrolled sugar, really high sugar, but it's kind of a mystery why it occurs. But those can all cause venous hum. Just some more fun facts here with regard to abdominal aortic bruit. It can be found in normal people. One study, about 12% of healthy people had this, had an aneurysm which generated a bruit. And they did not. They had a bruit, but they didn't have an aneurysm on CT. So if you hear a bruit of the abdominal aorta, don't scare the patient. It might be completely normal. You need to order an ultrasound or CT to see if there actually is an aneurysm associated with that bruit. Abnormal bruits from large aneurysms tend to occur in younger people under the age of 40. So that's kind of, you think everything's older people, but not that case. These non-pathological bruits also occur in systole. They should never go into diastole. How about bruits in other disorders? Things other than aneurysms and plaque buildup that we discussed can also do it. Cancers. Sometimes the growth of the cancer, this tumor, can pinch blood vessels within the organ, within the liver, or within the pancreas, and cause turbulent blood flow within the organ. It's still turbulent blood flow, but it's caused by liver cancer, and it's caused by cirrhosis of the liver, can also, because the liver scars. It gets big at first and then it shrinks later, and it can crush blood vessels to the point they make a bruit. So you don't always have to have an aneurysm to have a bruit. It can be from liver cancer and cirrhosis of the liver, or pancreatic cancer for that matter. And those bruits would be auscultable in the left upper quadrant and the right upper quadrant. Even in the epigastric area for liver cancer, depending on what lobe it's in. All right, let's talk about friction rubs, and we're out of here. Friction rubs sounds like, I don't know if you can hear that or not, but it's like I'm rubbing, my hands are really rough. So I'm rubbing them together. Really fine sandpaper, if you rub it over each other, it sounds like that. And you can Google it and listen to those sounds online if you want. I'm not going to test you on those. But it sounds like sandpaper being rubbed together. You always want to use the diaphragm. These are higher pitch sounds, so use the diaphragm. They're found in the costal margin about 6 inches out from the midline. So they're outside of the renal arteries. And yep, that's where you auscultate them and see if they are there. Hopefully they're not there. If they are, what do they indicate? Some bad stuff. Again, that liver cancer. It's usually secondary to an inflammation of the peritoneal lining. So it's a peritonitis that started. It's typically secondary to liver cancer. That's in the right upper quadrant, midclavicular line. Splenic infarct, left upper quadrant, or pancreatic cancer, again, carcinoma in the left upper quadrant. All right, thanks for listening. I will put a link to the video because usually after I lecture like this, we do a demo and I show you how to do these techniques. So make sure you watch that and see you later. Email me those questions.